order. Good afternoon and welcome to the Women and Equalities Select Committee. Today we are holding an oral evidence session on the health impacts of breast implants and other cosmetic procedures. In our first panel, we'll hear from, they're all online, so just for everybody else that's in the public gallery so they can see us, Professor Carl Hennigan, Director of the Centre for Evidence-Based Medicine at the University of Oxford, Professor Michael Coleman, Professor of Toxicology at Aston University. His camera isn't working, but we will be able to hear him and he can hear us. And Professor Prabhath Nanayakara, Professor in Acute Internal Medicine at Amsterdam University Medical Centre. Thank you very much, all three of you, for joining us today during this evidence session. I will crack on and hand over to David.
Thank you very much, and thank you all for joining us. If I can, I'm going to start with you, Professor Nanayakara, and I'd just like you to explain to us the difference, please, between a typical breast implant and a PIP breast implant. We can't hear you.
Sorry, Professor, may we just stop one second? Can we just check on the sound? Should we be able to hear him? You're unmuted now. Okay, go ahead, Professor. No, we still can't hear you. I'm sorry, we're having some technical difficulties. It should be working. We will come back to you, David. Are you okay to just see if there's...
That's fine. Would anybody else like to take that question? Maybe Professor Hennigan?
Okay, the problem is us.
It's us. Yeah,
Sorry,
we can't hear you neither.
We'll just pause
Can
the
you hear
session
me?
for now.
Yeah. Can you hear me?
There we go. Okay.
There we go.
Oh,
Hi,
Professor Coleman.
Professor Nanayakara again. Can we hear you? No, we can't hear you.
I can.
There we go. Perfect. Okay, so we'll go as we were. We'll put that question to Professor Nanayakara, if we can, please.
Thank you very much. The difference between PIP and not PIP implants is the PIP implant probably ruptures much more often. They say it's about 3 to 5 times the rupture rate. So the patients with PIP implant who we saw in the past, they had in my opinion, high rupture rate and also spread of silicone all over the body. That's the first thing. Second is they used industrial grade implants, which is much cheaper than the medical grade implants. And the medical grade implants also cause problems in patients. And PIP implants, in my opinion, would cause more problems.
Okay, that's really interesting. Perhaps coming to you, Professor Coleman, do you agree with the government's guidance that a ruptured PIP implant does not pose a serious health condition?
Right, can you hear me now?
Yes, we can hear you.
Yes. Absolutely don't agree. The issue with the PIP implants is they were so poorly manufactured, as Professor Nanayakara says. They were made of very poor quality silicone. If you make a polymer, you need to have a proper process and how to use your monomers. And unfortunately, the monomers were very poor quality. They're very cheap. The polymers didn't hold together. The outer surface of the implants was uneven, was prone to rupture. In one study, only about a third of the implants that were removed were complete. The rest of them were either ruptured or damaged in some way. So the advice that this isn't a problem is ludicrous. It's just utterly ludicrous. There is a problem, and these implants were not fit for purpose when they were implanted. So the fact they've been inside women's bodies for anything up to 10, 15, sometimes many decades, the chances of their rupture is extremely high, as Professor Nanayakara says, up to 6 times more likely, because they simply were not capable of withstanding the process of being in the woman's body. Also, they release the monomer, the D4, D5, D6, the silicone building blocks of the polymer, if you like, because the implants were so permeable. Things go in and things go out. The silicones go out, they go into the women's bodies. even if the implants are removed, for years afterwards, silicones can be detected in the women's blood from the implants for years afterwards. So the silicones enter the women's bodies and leave very slowly indeed. So the idea that this isn't a problem is just simply wrong.
So I really appreciate your answer, Professor Coleman, but I'm just going to press you a little bit more. So I think we can appreciate that there's a problem through the design of these implants. Do you think it poses a serious health condition, health risk to women when these implants fail?
Yes, because once the silicone is released into the body, we know that silicone or siloxanes, which are the components of the implants, we know the siloxanes appear to have an effect, what's known as the adjuvant effect. What they do is they stimulate the immune system in many women, not all, obviously, but in many women. And this is an effect which is used in vaccinations to try to make vaccinations more effective, to stimulate the immune system. And it seems that siloxanes have this ability to cause this stimulating effect. Hence the effect, the overactivity of the immune system seen in breast implant illness. And also this is partly also linked to the cancer related to these implants. So there is no doubt at all that releasing silicone in those quantities into women's bodies is a significant hazard, very significant hazard.
Thank you very much. Professor Nana Yakara, do you have something to add to that?
Yes, what I don't understand is we advise patients with silent ruptures to explant their implants normally, every implant. When PIP implants have a 3 to 6% chance of rupture, telling them there's no problem at all, you have no problem as long as you have no symptoms, that's not logical to me. I would say that.
Thank you, that's really helpful. Coming to you now, Professor Hennigan, is it reasonable to assume the majority of women with PIP implants will have already had them removed or replaced?
So I think this goes back to the previous question you asked is the Bruce Keogh review was in 2012. So what we're talking about is our view of the evidence some time ago. And what's happened over time is the emergence of more and more evidence linked to breast-associated illness, but also to the lymphomas. And what we find is we're in a world now where the evidence we supply cannot inform a patient about the benefits and the harms of this device. I set out in my report the problems with the registry, and that's an issue within our ability to inform women. So I think what we're seeing, the first few suggestions are telling us we have an issue. There are lots of uncertainties because of our failures to collect and report an evidence base like we do for many other implants, like the National Joint Registry for hips and knees do a much better job because of the failings of metal hips than breast implants. My perspective is because this is considered as a cosmetic intervention, it's not an issue that the NHS takes seriously. However, I consider we're in a world now where the complications are increasing and we have a duty to do something about that in terms of collating the evidence and reporting it appropriately.
Thanks, that's really helpful. I just want to pull you back to the question though. Do you think that the majority, is it reasonable to assume the majority of women have now had these removed, or are there a large number of women still out there with these PIP implants?
So the answer is yes to that. The exact number is not known because the registry that was supposed to come into force in 1993 was enacted in 2016 is actually, as far as I'm considered, failing. But that should have a duty to report the number of women with PIP implants. We know in 2012 there was an NHS call to women to be able to be seen, but that was only mandated those women who had operations within the NHS. All of the private women, we don't know exactly the number of women who had PIP implants, but it's likely to be substantial And it's much more than many other countries because of our mantra, which was these are safe and you could carry on with these much longer than many other countries. Particularly, the reason why the problems emerged in the first place was that these implants didn't get into the United States of America, where they have much tougher regulation. And that led to the cost pressures that led to also the use of the industrial grade silicone that led to the PIP implant scandal. So there's an issue about regulation, but another important issue is to be aware that our post-marketing surveillance requirements come into force next month with the amendment. That means we should be collecting much more stringent data in the post-marketing surveillance world. And we have an ability, and your committee has an ability to determine what that should be for implants.
Okay, thank you very much. Very helpful. Professor Coleman, coming to you. Do you think sufficient research has been undertaken in the UK on the risk of PIP implants to women? And if not, why do you think that's the case?
Absolutely not. There is nowhere near enough information. We don't know enough about what the components that escape the implants, the siloxanes, D4, D5, D6, these small chemicals which circulate in the women's body. We don't know enough about what they do to humans. We know that they have some negative effects on animals. We know there's animal studies showing they impact animal reproductive systems. They derange animal cellular systems. They also cause damage to animals and they're developing in utero, in the womb. And this is moved forward to damaging the adult animals. Now, we know that in animals, and we know approximately the concentrations that cause that. Now, we don't know whether this happens in human cells other than some very limited studies which show that D4 does derange human cell control processes. And unfortunately, that's only been done in some very limited studies. We need a lot more research to understand exactly what D4 and D5 and D6 are doing to the human body, to human reproductive systems, and also to get some idea of how they're impacting or communicating with the immune system, which is probably linked to why we have breast implant illness.
Okay, great, thanks. And final question from me. Is there anything else any of you think the UK government should be doing that they're not doing currently regarding PIP implants?
If I may say something, in the Netherlands, there were about 2,700 patients with PIP implants. Those were removed, paid by the government. We started our clinic in 2012 for all the silicone implant patients with problems. They could come to us and we could examine them. Up until today, we see patients who have removed their implants in 2012 coming to us with sometimes severe complaints. And what we also see is I have many patients who had leaked implants. They still have silicone deposits in their breast and also lymph nodes, and they are suffering from it. So I'm sure after seeing more than 2,000 patients with implants, not only PIP implants, PIP implants, but all the silicone implants, I'm sure there are many patients walking around with complaints. The biggest problem with Western doctors are we think that if we don't describe a disease, that it does not exist. So the disease does not exist because we have not described that. So your question, I'm very sure I saw it 2 days ago, a patient with PIP implants, which were removed in 2012. She has still silicone deposits all over the body and she's still suffering. So I'm sure there are women walking around with lots of complaints. We are not looking for it. So-called street light effect. We look for things we know and we don't look for things we don't know or don't believe that exist.
Professor Hennigan?
Yes, so just to clarify, what Professor Coleman was talking about was the basic science research. And you can split research into two areas. The basic science, what happens when you put this silicone into the body? What happens? You can do that in animal models and humans. And then you've got the applied health sciences, the epidemiology and the evidence-based medicine. And there are two substantial failures. Number one is we don't know which implants are being used and on what evidence they are based on for approval. And that is supposed to be enacted by EUDAMED within the new European directives, that there should be a website that shows you what are the devices that are approved and what evidence are they approved on. That has been stalled for quite some time, but we could enact such a database. The second aspect is, like I've said, is our registry, which hasn't published any annual reports yet, and the data has been down since June the 30th. So what devices and what are the current UK complication rates? We can't address and answer that based on nearly 20,000 implants a year being put into women.
Thank you, David. Just to follow up and be clear on this, Professor Hennigan, are you saying that we currently don't know, because this register is stalled, we currently don't know in the UK what implants are being used in the UK in people's bodies?
Correct. We know the number of operations, but just to be clear, the National Joint Registry publish interventions and outcomes annually. I have asked this of the implant registry, why this is not happening. And they are saying they are this is quote, currently assessing whether this data can be published in the future as part of the outcomes registries program. Currently, it's managed by NHS England. And the problem is NHS England are about to be disbanded. So my perspective is if we don't move it out of there and give some competent body to manage this registry, we may not know what's happening for the next 2 to 3 years.
How do we know, Professor Hennigan, if we cannot know what type of implants are being used, that there isn't something similar to PIP still being used, or something of industrial grade silicone being used instead of medical grade? How do we know that there isn't just another implant by another name that is substandard and causing illnesses and has a high failure rate?
Well, this is the proposal. What the new MDR is supposed to address is the problem of equivalence. My breast implant is similar to previous ones, therefore we're going to let it on the market. The US FDA has a much more stringent process to prevent that happening and requiring clinical trials. The new EU MDR, but the problem is that's not to come into force till at least 2027. And it's not till 2030 until we have the UK certification process comes fully in process. That means up till that point, you can still adopt based on CE marking and EU regulation. The other issue you've got on top of this is then you've got the tourism problem, that we've got people going abroad and we have no idea what they're bringing back into the country. So in terms of the implant. So this is a huge issue that it needs to be, I think your point is, needs to be addressed.
Thank you, Professor Hennigan. We are going to touch on the tourism aspect later on, but there's one other question I wanted to ask, because there will be predominantly women listening to this, or may read about it later on, who will be thinking, I had a PIP implant, or I don't know if I had a PIP implant. How will they know what implant they have? What's the best advice to do that? And if they had that, how can they be certain and sure that it hasn't spread elsewhere and that silicone remains in their body? I think that's Professor Nana Yakara and possibly Professor Coleman as well.
So in all the scandals that emerge, you always get the same problem, is that women or individuals tell you at the time they had this procedure, nobody consented me and told me about the true harms. Mm-hmm. Second is then, could you consent somebody appropriately? What you would want to do is be able to say, this type of implant that you're about to have, here's the benefits in terms of cosmetic and procedural and issues, but here's the latest data on rupture rates, breast implant illness, the latest data on rupture rates and replacement, and the cost to you. In the UK, I don't think we can, I've set out we can't do that, I think, comprehensively at this moment in time.
Thank you, Professor Hennigan. Professor Nana Yakara.
Yeah, you know, in the Netherlands since 2015, we have a breast implant register where they exactly know which implant you put in. Before that, we had the same problem because even PIP implants, when the patients got the call from the clinic that they have a PIP implant and they have to remove it, they were surprised. They didn't know that. That's one thing. Your other question is, how do you know the implants are still intact? MRI has a sensitivity of about 85% to show that implants are intact. But what we also see is there's also sweating, the leak from within without a rupture. And I'm sure that lots of these patients have silicone in their body or even in lymph nodes. And for that, you need a really thorough clinical examination by a physician who has experience about this problem. So your question, first of all, we don't know what kind of implants they have. Second, to demonstrate rupture or spread, you need a clinician and MRI or some other ultrasound also.
Professor Coleman, just wanted to come to you quickly, just to answer the second part of my question, which is, if a woman is concerned that she may have had a PIP implant or her implant, any implant has ruptured, or that they've been removed and there still remains silicone within her body, what signs should they be looking out for, and what action do you think that they should take or would advise to take? Professor Coleman.
Well, I think this, well, essentially, I'm not a clinician, so this is outside the my immediate expert opinion. However, but I would say that if they think they do have a PIP implant, they should have it removed. As simple as that. If they have any signs of what we now know as this breast implant illness, which is it's not that well characterized, it's complex, but if they've been had a number of issues with issues such as brain implant illness, breast implant illness, symptoms such as the brain fog, the various immune issues, the muscle issues, which are very widespread, they should be talking to their GP. But ultimately, I think that the PIP implant should be removed. We also should be concentrating on warning women in the future who are prospective implant recipients that there's enough evidence to suggest that women that have potential autoimmune issues, even if it was something like asthma or something like that, if they have an overactive immune system before they have these implants in the future, I think they're very much at greater risk of developing problems several years down the line. So I think women are not properly informed of the risks of implants in terms of triggering almost an unending engagement with their own immune systems. That's my opinion of that on the scientific basis of what seems to be happening.
Thank you.
As a clinician, I can fill up if I may.
Yes.
If you want to look for complaints, most of the breast implants which are ruptured cause local complaints, and like pain, changes in the feeling, not being able to wear tight clothes. Most of these patients take it for granted for a couple of years, and they also sometimes have shortness of breath. Breast implant illness, we have studied extensively and also published more than 10 papers on it. They have symptoms like morning stiffness, joint pain, muscular pain, changes in the skin, losing hair. So if you have this, and the other thing is 70% of the patients with breast implant illness also have local complaints. And what we see is when they listen to us or when they see some TV program talking about it, then only they realize that their complaints, which are vague, can be due to the breast implants. So if patient has these complaints, they have to see a doctor, and they have to maybe even get further diagnostics and then explantation. Not everybody with the implants gets sick, but some women get sick and some women get very sick.
Okay. Before I move on to Rosie quickly and then on to Alex, Professor Nana Yakara, the list that you have just outlined could also be many different illnesses within a woman, particularly if you're looking at perimenopause or menopause, the sweating, the shortness of breath, the hair loss, all of those things, the brain fog in particular. Yeah. We know that we just heard Professor Hennigan say that this isn't being taken seriously in this country because it's seemed as a cosmetic procedure rather than a medical procedure. Is it also the fact that perhaps women aren't being listened to? We'd done a report on medical misogyny, and we found that women just are not listened to when they come in and they say there is something wrong with their body. Is this also part of the problem?
I certainly think so. Most of the patients who come to our clinic has been seen by 3 specialists, sometimes 10 to 15 doctors. I mean, the diagnosis of hysteria comes pretty often in women than in men. And there have been studies published in BMJ, in JAMA, that women do not get the benefit of the doubt. That's why we also started this. So what do? We talk to them and see whether we could exclude all the alternative explanations. And if they have the classical symptoms, we come up with a diagnosis of breast implant illness. We have seen more than 2,000 patients. So your question, in my opinion, the patient should get the benefit of the doubt, not the doctor.
Okay, thank you.
And at the moment, we are giving the benefit of the doubt to doctor and the industry.
Thank you. Rosie and then Alex.
Just a quick one. I think it's probably Professor Hennigan who can answer this, if at all. You were talking about the different kinds of implant, and we heard that there's a register in the Netherlands. So if there's no register, NHS England, presumably each hospital, CEO, whoever gets procurement, can order their own types of implant from wherever you get these things. And then I'm assuming that each private clinic does their own thing and has their own supplier. So do we know at all where these implants are, who's getting them, is there any regulation of that at all?
So just to correct the facts, we do have a registrar.
Okay.
Managed by, my understanding is NHS England. In 2023, 18,367 patients underwent operations at 335 different organisations. Okay. Point is, there's no report or outcomes on that. What I'm saying is the other registrars are mandated to produce an annual report updating us. So you would be sat there with a report from the registry saying, these are the implants we're in. Here's our 10-year follow-up, because it's been, 9 years, it's been going since 2016. And you would have, and I would have, an annual report for which we could use that information to help inform patients. Is that clear?
Yeah, thank you very much.
Just don't have the outcomes of the report, and at the current moment, it's unavailable, and it's saying the dashboard's not working, and it's not been. That's for 9 months.
Thank you very much, Alex.
Thank you, Professor Nanayakara. I wanted to ask you first. We've covered some of this, so just really succinctly, can you outline the symptoms referred to as breast implant illness?
Breast implant illness, as I told you. Mostly these people are really debilitated. Severe tiredness, not just tired, but severe tiredness, morning stiffness, pain in the joints. And they always complain that they have a feeling as if they've got a flu all the time. So muscular pain, because of that, they cannot exercise. And they have sometimes, when they have implants for a long time, they have also allergies, skin allergies, and we also see that allergies are getting worse when the implants, after the implantation, and 70% of these patients, about 70 to 80%, also have local symptoms. And local symptoms can be from atypical chest pain, shortness of breath, up to a tightness, a feeling of tightness. So there's a scale of symptoms what these patients have, and that's called breast implant illness. But what we also see is, of course, scientifically, it's never demonstrated that autoimmune diseases like lupus or something else is caused by breast implant illness. But when they have breast implant illness, they have a typical cluster of symptoms. So what we see is in the hospitals, there are patients lying with all kinds of atypical diseases, but nobody puts the link to the breast implants. And that's what we do also. So your question, there's a scale of symptoms which I listed now, but you have to think that they're linked to the breast implants, mainly because of local complaints also. So it's systemic and local complaints, it's combination.
Thank you. And have you seen a rise in patients reporting these kind of symptoms?
Yeah. That's because also the awareness is more. And in the Netherlands, there were lots of television programs which spoke about this, and that's why some people say it can also be a nocebo effect. That when the patients know that breast implant cause symptoms in some patients, others would get it also. Of course, diseases have part reasons, so that should be one reason why this is increasing. But I'm sure there are many other reasons for the breast implant illness. So your question, is it increasing? Certainly. We have a waiting list of 13 months. Hundreds of patients are waiting to be seen by us, and we have started a consortium of clinics in the Netherlands to see these patients.
Thank you. Professor Hennigan, are you also seeing an increase in patients with these symptoms?
Well, I'm a GP who works in urgent care, and so I don't see within that context, but I did want to make some important points. One is that it's not classified as a disease, and that has important issues within then how it's reported and what's picked up. I suspect as more, and the problem is because of the lack of evidence, but as more evidence accumulates, I'm sure it will get a disease classification. Two is the latest systematic review data based on 31 studies shows that 84% of individuals' symptoms improve with removal of the implant, which is an important aspect in terms of diagnostics and causation. The third thing is to truly understand, because of the vagueness of the issues, is we need a prospective study. At the time of implant, you consent people to be followed up, and you start to understand and ask them about their symptoms. That's the type of study I think Professor is talking about, and I think we need one of those in the UK to fully understand what's happening and the issues at hand.
Thank you. Professor Nanayakara, I'd like to come back to you on this one. What percentage of women who get breast implants report negative side effects, and do you know why not all women are affected equally?
The percentage of women reporting complaints can go up to 50% if you include local complaints. And in the Netherlands, for example, there are about 13,000 breast operations. Up to 40% are re-operations, not the first-time operations, which means that almost 1 in 2 get a re-operation. And within 15 years, almost 40% of the patients get a re-operation. So that's the answer to your question. It varies according to every cohort, but most of these women get local complaints. They end up at the plastic surgeon and get it operated. The women who end up in our clinic are patients with a little bit of local complaints, but more systemic complaints. So the biggest problem is the local complaints. Second is the breast implant illness. Why do they get it? It's probably also genetic predetermined. So not every woman who gets the implants gets the disease. In our cohort, we showed that almost 70% had pre-existent allergies, which got worse after implantation. So we think there's a genetic predisposition, just like some other diseases. And if the implant leaks, let's say PIP, if it leaks in these patients, they will get severe complaints. We're looking for the genetic predisposition just to see whether they could predict who will get symptoms, but we are still not there.
Thank you. And to what extent, you've touched on this a little bit, but to what extent does the removal of a breast implant completely alleviate the symptoms?
In our cohort, just like Professor Hennigan told, 2/3 get better. And what we see is if the implant is longer than 10 years, it looks like they don't get better because the point of no return has reached, probably. So 2/3 get better in our cohort.
Thank you. Professor Coleman, I'd like to come to you first on this one, please. What research has been done on the causes of breast implant illness?
I suppose the problem is that obviously research on the specific causes, it's very, very difficult to do. Obviously on women, you have to look at animal studies where they've looked at the components of the implants, the small siloxane chemicals which leak out of them. And the industry has spent a lot of money on research in looking at these components, siloxanes, and looked at them in animals. They do cause problems in animals. They do cause some issues in reproductive systems, as I mentioned earlier. But this has not really been followed up at all in human levels. We know that these chemicals are found in the blood of women with implants. Also, these chemicals were, until relatively recently, found because of cosmetics. D4 and D5, D6 were in lots of different cosmetic preparations and were absorbed into people's bodies, but far greater concentrations are found in women's bodies with implants than those that just use the cosmetics. And the problem, we don't know what D4 and D5 and D6 are doing to human systems. We don't know the exact link between the impact, well, how these small chemicals, these small sort of football-shaped chemicals, how they actually cause all these different disseminated reactions. And one of the big problems, if you look in toxicology, if you look at the effect of alcohol, people say, oh, that's your liver. If you look at vaping, oh, that's your lungs. Whereas with these chemicals, there's no one organ which is impacted. So it's quite difficult for people to grasp how are we linking these chemicals with all these complicated different effects in the brain fog, in the endocrine system, in the muscles, the joints. And that's the real difficulty, trying to work out exactly how these siloxanes cause these problems. And the EU have recognized that D4 is a problem, and that's going to be pretty much banned from the middle of next year, except for use in making implants, if I may add the strangeness of that. But D4 is being phased out of cosmetics and is decided that's too toxic to release into the environment. It's an aquatic toxin, but you can carry on making implants with it, which is rather strange. So from a scientific perspective, that's not very consistent. So we need to find out much more about how D4 and D5, D6, the related siloxanes, how they are causing these problems, because they're found in women's bodies, they're found in concentrations, and when the implants are removed, the polymers, the siloxane polymers remain in their body. Particularly had a rupture, and that we need to find out a great deal more about.
Thank you. Do you think then, in light of that picture across the EU and the irony of that situation, do you think it would be better if legislation prevented breast implants from containing silicons like D4?
The big problem we've got is that if you don't make implants out of silicon, what do you make them out of? Yep. And obviously in the US, they tend to use saline-filled implants, but they have a silicone envelope, a silicone barrier. At some point, silicone is in the process. The industry, as far as I'm aware, has behaved a little bit like the oil industry. We're always going to be using oil. We don't need to research any alternatives. They've been very narrow in terms of not looking for materials which are not likely to impact the human system. It was assumed that silicones and siloxanes were inert, and it's been assumed they're inert for the last perhaps 50, 60 years, and they're not. The evidence now is strongly pointing to the fact that they do impact the human body. The human body sees them, recognizes them, and the siloxanes, these components are the root cause of the problems with implants. And because the PIP implants were so leaky and so badly made, they're the most acute phase, the most acute manifestation of the problem. And in the future, people, I'm sure, will want implants. That need will never be satisfied, but they shouldn't be made out of siloxane polymers.
Thank you.
Thank you very much, Alex. Catherine.
Thank you. And just before I start, I just wanted to say a big thank you to Fleur Anderson MP, who's raised this issue consistently in Parliament and really tried to raise awareness of it, and maybe even thanks to her that we're doing this inquiry. And One of my questions was, in France, so the French government urged 30,000 women to seek removal of the implants, and that was undertaken by the state. Do you think the UK government should have done that? Anybody who wants to respond?
Absolutely, yes. I think we'd probably all agree on that one. Yes, they should put their hand in their pocket and pay for this.
And
just to say, in 2012, there was an NHS offer for women with PIP implants, but that offer has sort of disappeared off the horizon, if you like. So I think that offer should be reiterated to women. The problem is it only applied to those who had their implant within the NHS. Yeah. So there are women who had it done privately and weren't aware of these issues at the time, who have to go privately and fund them. That's my understanding. And so...
Yeah, but we have compensation schemes as well, don't we, for infected blood scandal, for other different scandals, and I just feel like so important, and the government should most definitely have a compensation scheme for women who've undergone these PIP breast implants, in my opinion. And it looks like everybody agrees.
Can I just come in on that point?
Okay.
Is what you really need is a mandatory insurance scheme that at the time of implant puts insurance in place that says this is going to go wrong, we have to going to pay for it in the future. You could tie that to the quality of the evidence. So if the evidence is derisory, the cost of the insurance should be huge. As soon as you develop better evidence, your insurance should be less. But the NHS or whoever's putting these in needs an insurance system because they do go wrong.
Can I just ask a question for clarification? Apologies, Chair, I'm going a bit off the questions that I was supposed to ask, but I don't understand. Have the PIP implants been banned here in the UK?
Yes, definitely. Yeah.
They have. Okay, good. Right. So a question then about the rise of breast implant-associated anaplastic large cell lymphoma, or BIA-ALCL. So has there been a rise in reports of that? And if so, why? Shall I start with Professor Nanaya Yakara?
There has been a rise, according to FDA also. And the problem is with the ALCL also, we think you got to look for it to find it. Because when you remove the implant and also remove the capsule, mostly in private clinics, they don't check it under the microscope. So I think there's definitely an underreported report of ALCL, and there is a rise. Mostly is the prognosis good, but there are women who have died from it. And I have a survey, for example, how many times? I have a survey here, international survey, who says that 31,000 British women has received implants in 2023. It's much more than what Professor Hennigan also says, because lots of women are getting that in other countries like Turkey and Spain and all that. And I think they don't check for ALCL.
Okay. And do certain types of breast implants, such as textured versus smooth, have higher rates of BIA-ALCL reported?
Yeah, that's shown. Majority of women has macro textured implants. So it's also worth saying that these macro textured implants were introduced because they thought they were better at preventing local symptoms. But what we found out later is that they cause most of those patients with ALCL at macro textured implants, and it looks like they have a strong association or even causality to cause these symptoms. Yes, so macro textured implants, but there are cases of ALCL also with PIP and some smooth implants, but they're the minority.
And one final question from me at this time. Is there any risk of developing BIA-ALCL after having the implants removed?
They have described one case after removing the implants in the capsule, but I wonder again, there is underreported. Yeah, so there is a risk, but the risk is not very high. ALCL risk is also not very high. The incident can vary from 1 to 3,000 or 1 to 30,000 according to all kinds of things, but I think it's going to increase. So your question, after removing, the chance is low, but there have been instances.
Thank you, Catherine.
Can I just make one quick point? Is that possible? Just one point. I think it's very important to point out that BIA ALCL is not a breast cancer. It's a cancer of the immune system. And I think that's a very important thing to see in terms of the context of the impact of implants and siloxanes on the immune system.
Thank you, Professor Coleman. Kirith.
Thank you, Chair. My first question is for Professor Hennigan. To what extent are patients adequately warned of the health risks of breast implants prior to getting them?
I think that's a recurring problem that we've seen among a number of devices, whether it's surgical mesh, e-Sure, hormone pregnancy test, or sodium valproate. I think the answer is it is not. I cannot understand how you can get informed consent at the current time. Importantly as well, given all the problems you've heard, FDA recommendations state that you should have an MRI scan at 3 years after the implant is first put in, and then every 2 years after that. The problem is the cost of the MRI scan and the monitoring far exceeds the cost of the implant. So there's a systematic problem in patient safety that we're not addressing that doesn't allow us to inform patients with what I consider a true informed consent.
Yeah, that's quite a stark picture there. You mentioned earlier you have some experience being a GP. Is that right?
Correct.
So do you think GPs in the UK typically have sufficient awareness and understanding of BII and BIA ALCL to believe women when they present with relevant symptoms? And what do you think could be done to better educate medical practitioners on these health conditions?
So I'm an academic GP who works in research and teaching. So as Professor of Evidence-Based Medicine, I have an understanding of these issues at hand in the device regulations. My colleagues are not aware of these issues at all. It is very difficult, though, to put more workload on GPs. You've got to remember the range of problems that they see, and the amount of advice and guidance that come in means they're overwhelmed. The key issue here is for the regulator to improve the post-marketing surveillance and ensure the alerts are transmitted to all doctors and all trusts about what is going on. And we have to do that well. The problem here is if we don't do that well here, I think one of the colleagues online said, you've got a problem with more women going abroad to get their implants, and you'll increase the issues at hand. So what we should be saying is we are going to provide a safe system that's world leading in the evidence base. In doing so, please come and do it here and don't go abroad, where actually the problems are bound to be much worse.
So in addition to the regulators that you've mentioned, do you think there needs to be updated and regular advice and guidance for medical practitioners around these?
Well, I've said previously we need the annual update from the registry. We need a report annually that goes to yourselves, Parliament, and to all trusts and everybody saying this is the latest state of what we know. The second is we need to know what implants are on and what evidence has been used to approve those implants and what follow-up evidence is there. Remembering in your new regulations that come into 2010, the FDA requires 10-year follow-up studies in the post-marketing surveillance arena. So the manufacturer has to follow them up for 10 years and provide updates to the MHRA. That should be mandatory for all devices.
Okay, thank you. And Professor Coleman, you touched on this earlier. Do you think there's been adequate research into the safety of breast implants? And if not, in what areas is research needed?
I think the most direct way in is in the advice process, where you're advising women when they're thinking of having the implant, what risk factors might they already have? Yeah. And Professor Hennigan touched on this idea of the insurance. Insurance is, well, certainly medical insurance is invalidated if you have a pre-existing condition. They'll get out of paying if you have that. Now, the evidence, I think, so far seems to suggest that if you do have issues with your immune system and overactivity in your immune system, a history of autoimmune disease, there's a much greater likelihood you'll have a problem with the silicone implants because of this adjuvant sort of accelerating effect on the immune system. So women need to be aware of that. So we need to do more research into strengthening that, or having more understanding of that link, so that women in the future can be spared having years and years of suffering as a result of having an impact which they're fundamentally likely to be incompatible with. Many women can live with implants for many years without a problem, but a substantial number of women, it seems, the literature, certainly scientific and medical literature, suggests will have a problem, and these problems will not go away for quite a while. Even if the implant is removed, there are issues once you've triggered the immune system, as Professor Nanayakkara was saying, gone past the point of no return, when the immune system is so over triggered that it will essentially be very difficult to stop. So you do not want this to happen. You need to prevent this from happening, and we need to understand much more about the link between the implants and the immune system and other pre-existing conditions.
May I add something? We have a national protocol. We have been working on it for more than 12 years. Still, often doctors don't believe in the diagnosis that breast implant cause symptoms. So most of the patients who come to us are frustrated and angry. And I understand it, because you have been sick for, let's say, 10 years. And these women, they lose their jobs, they lose their relationships, they're divorced, and at a given moment they're about 50 and they have nothing. They have no money to pay for MRIs in the private sector, so they're really frustrated. This is because they need recognition, and in spite of lots of work, still they don't get it sometimes. So there is lots of work to be done also during the training of doctors, and also creating awareness among the doctors about the problem also.
Thank you. And Professor Coleman, do you think patient safety is overlooked when it comes to women? And do you think that there are signs the cosmetic industry downplays or hides the risks of implants?
I would agree with that. I did see a study where surgeons were asked what coloured their decision as to which implants they used, and only about 29% of them made a decision on the implant based on any risks of cancer. So they know that the textured implants are linked with BIA, ALCL, and they made their decision more or less on the implant, whether or not whether it be a capsule formed or whether the implant would move, which is to choose the textured implant, when the evidence is gathering that textured implants are clearly a much greater risk of this cancer. So they were far more interested in the, if you like, they come back on them essentially. Is this implant going to move? Are you going to come back to me for this? Rather than the women having this risk, because the risk is very much strong with the text. Almost all the cases, I think there's about 1,200 cases so far with BIA, ALCL, almost all with textured implants. And the industry was concerned that the textured implants take up and manufacture and the rest would be impacted by this. That seemed to be their primary concern on their income stream, really. The smooth implants, obviously, there are issues with those. They're more likely to move. There's more likely to be a capsule, as Professor Nanayakkara mentioned before. But the issues seem to be more about the practicality of the operation and not necessarily about the long-term health of women. That was my perspective from that study.
Thank you. And Professor Hennigan, do you think there is a case for better follow-up monitoring of women who have had implants? You did mention the MRIs there and the cost, but do you think there does need to be a better system for monitoring and follow-up?
There needs to be a change in how we view patient safety when it comes to implants. I think that's what you're hearing. Yeah. And this committee meeting is recognising a signal that there's a problem. And that problem is multifactorial, lack of evidence, lack of ability to inform patients, and clearly a patient safety issue. Yeah. What happens in all the scandals is there's a significant delay before we take action, concerted action, to fix this issue and noticing the signal of harm. And somehow your committee has to escalate and bring forward the actions. There will be no new regulation enacted for probably the next 10 years. So one of the key issues is to work within the existing systems and make them function better. I'm happy to write to the committee about the 5 or 6 things that I think could happen within the existing regulations that we could do much better to ensure patient safety.
Yes, please. That would be great.
Thank you, Kirith. Just before we go back to Kirith, I just wanted to ask, I think many people might have Professor Coleman's words ringing in their ears about this being a cancer of the immune system, BIALCL, being a cancer of the immune system. That sounds incredibly worrying and incredibly serious. Could you talk about the prognosis and the treatment for this cancer of the immune system, please, Professor Nanayakara?
Yeah, it's a form of non-Hodgkin's lymphoma. So what you see is if you remove the implants on time and also the capsule, the prognosis is quite okay, quite good. But I talked to my hematologist before talking to you also about it. We have had patients who had to go through chemotherapy and who had also complications of that also. So the short answer is prognosis is good. If you think about it, detect it on time. But there have been deaths, and it's becoming more. There have been deaths, definitely. It's becoming more, but the prognosis is good.
Thank you very much. Kirith.
Thank you. Final question from me, and I'll direct this to Professor Nanayakara first. What would be your advice to women considering getting breast implants?
If it's my family, I would say no. If they are known with a severe allergy, I would say no. If they have a family history of connective tissue diseases, I would say no. And any other women who ask me whether they need to get breast implant, I would say I am biased, so I would say no. But I don't know what I don't know. I don't see what I don't see. I don't know how many patients are there, women are there without complaints. So it's a long answer, but this is what I do. My family members, I would say definitely no.
Thank you. Professor Hennigan?
So when you decide, as an analogy, to have a hip implant, you do it because you have a severe problem. You may not be able to walk 100 yards. I would not recommend you to have an implant if you could walk to the shops and back and go run down the streets and operate normally. So the key issue here is when you're having an implant, you have to recognize that actually you don't have a severe issue at hand, and you may have reasons for doing that that are legitimate, but all the harms will be accentuated. And therefore, just like the professor, my advice in this situation would be to be risk averse and try not to have the implant and try to explain the long-term consequences when all the problems will emerge. Based on that right now, I wouldn't be able to consent somebody, and I would not be able to provide the operation because I say I cannot give you informed consent according to GMC guidance because of the problems we've outlined. And I think that's the key issue. We should pause them until we can fix these issues.
Thank you. Professor Coleman, did you want to add anything?
Well, finally, you've all seen the Terminator films when this thing comes after you and will not stop. You do not want to invite a sort of immune system terminator into your life. And the problem with the PIP implants is that thousands of women unfortunately have done. And if we can prevent this happening and find out more about it, what increases the risk, anything we can do to stop that. You do not want the immune system pursuing you for the rest of your life and causing you to suffer to this degree just because of a cosmetic thing, something, as Professor Hennigan was saying, something you don't need. You were fine before, and now you're not because of a decision you made to enhance your body. And it's too great a price to pay, in my opinion.
Thank you. There's some really powerful statements there. Thank you very much. Thank you, Chair.
Thank you very much. In the interest of balance, I should say that there will be some people that, particularly breast cancer survivors for reconstruction, that would really, probably on balance, really have to think carefully and hard. And obviously taking on board of what you said, informed consent, but also for trans women as well, where actually they wouldn't classify themselves as fine before. So I think it's important to make sure that we also have that as well in our minds. I want to say thank you to all three of you for your expertise, for your openness, for your honesty, and for your determination to listen and to help women who have issues with their implants, whether they're PIP or not, and to try and help us make better decisions in this place and hopefully in healthcare settings across the country. If any of you have anything that you want to add, please do feel free to add it into us in writing if you feel that something wasn't explored or you wanted to add something. But on behalf of the whole committee, thank you very much, and we'll move on to our second panel.
Thank you.
Thank you.
I don't feel well.
There wasn't any ambiguity there, was there?
I did raise it. That's pretty harrowing. We got Sasha. The answer to one of the problems is
I wasn't expecting it to be quite so definitive.
I've been saying that they wouldn't get their family to do it. That's you can't argue that. So you have to say that's what I
I don't know if you've
Research as well.
Oh, really?
I mean, not that it's just if it goes wrong, it goes horribly wrong.
Yeah, it is. Great.
lots of stories just before I stopped being a journalist about it. Massive problem. Do not know.
Oh yeah, okay.
Week
Thank you very much, and thank you for your patience. I'm sorry we've slightly overrun, but I think you can understand why that evidence was incredibly powerful and informative for the committee, so thank you. Welcome to everybody for panel 2, and a massive welcome to Ashton Collins, Director for Safe Face, Professor Vivian Lees, Consultant Plastic Surgeon and Vice President of the Royal College of Surgeons, and Sasha Dean, who has lived experience of severe complications following a liquid Brazilian butt lift. BBL is what we will use from now on as the term. Thank you all for being here and welcome. I'm going to hand over to Christine now.
Thank you, and thank you all for joining us. Professor Lees, I wonder if we could start with you and whether, I think we're particularly interested after what we've just heard, does the Royal College of Surgeons have any view on the safety of breast implants, particularly in light of the emerging evidence of the potential effects on women's health and what we've all heard today?
We are obviously open as practicing clinical scientists to new evidence which does emerge. So the position we take obviously depends on the evidence available at the time. So it's obviously concerning to hear some of the things which have been presented in the last session. There are very important benefits for breast implants, though. You've mentioned yourself breast reconstruction, and the psychological benefits for women who are particularly self-conscious about their shape are undoubted. So we don't want to deprive people unnecessarily of their implant, but we do have to make sure that they're safe, first of all. So we don't have a formal position on that, but we will be very mindful of evidence which comes forward.
Are there any plans to examine whether you need to make a formal decision or any inquiry underway?
We have the National Breast Implant Registry database, which started in 2016. All implants are logged onto that by responsible practitioners, and that includes the type of implant. So we do understand which is the manufacturer, they have serial and lot numbers, and the reason for putting them in has to be recorded. Obviously, the PIP implants were not put onto that database, but they are being captured as they come out again. So if an implant is removed, that's also recorded. New implants may or may not be put in. So there is some narrative around why that implant was used and why a subsequent set has had to come out. So we are gaining that information. I think it's absolutely right to flag the fact that we mustn't lose this database with what's happening to changes in NHS England. It must be migrated.
I'm sorry to pressure on that, but I mean, will this database be used to come to a view or a recommendation of any sort on the safety of breast implants?
The point of the database is to flag concerns, but I would probably agree that we're not capturing enough data about possible symptoms on it at the time of removal. So at the moment it's not set up to do a biannual review and record that. It's not. But equally, symptoms are not captured at the time of removal. It would capture, however, things like capsule contracture, whether the implant has ruptured or not, and any other concerning features at the operation itself.
Thank you. Ashton, I wonder if I could ask you, in recent years the number of cosmetic procedures has been steadily rising. What do you think is driving this?
I think there are two primary factors. Without doubt, the biggest proponent has been social media. I think if you look at, especially with non-surgical treatments, when they first came to the UK circa 20 years ago, they were very much the reserve of the rich and the famous, and nobody wanted to discuss having them done. Whereas with the advent of social media and reality TV, more and more people are happy to discuss the work that they've had, and in turn promote that work on social media. And I guess especially for younger people, that is where they look to get information, but also to find practitioners. And so it is a constant source of not only misinformation about how safe these treatments are, and they're not informing end users about the risks, and it is also a hotbed for unscrupulous practitioners to prey and target women into believing that they need these types of procedures as well.
And is the rise uniform across the board, or is it most notable in sort of certain demographics? And why do you think, if it is, why do you think that is?
I think it's the surge has definitely been more geared towards younger people, and so we've been established for 10 years, and in that time we've gathered patient-reported data on complaints and concerns, and we've helped over 15,000 members of the public either with unwanted outcomes or adverse reactions and complications, and over 50% of those have been from women aged 18 to 30.
Thank you. Sasha, I wonder if I could ask you those two questions as well. First of all, what you think is driving this increase, if you would agree with Ashton.
Yeah, I agree. It's definitely social media. For me, it was something that for my liquid BBL, it was something that I hated on my body for a long, long time. And so, yeah, when it started coming through, I thought that was definitely going to be the easy option for me. And seeing so many women have it done and it being deemed as safe, that's what spurred me on to do it, rather than the surgical route. So, but yeah, anything but safe.
It's interesting you say that. Do you think, you obviously believed it was safe?
I was told it was safe.
You were told it was safe. So would you say that perhaps that lack of awareness that we've heard about earlier, that needs to be addressed, and addressed quickly?
Yes, because they all know, the people that are carrying it out, that it is not safe. The clinic and the practitioner that did me knows it's not safe, and their social media is still saying it's safe. And they know that they nearly killed me.
Yeah.
Thank you, Christine. Shivani.
Thank you, Chair. I'd like to just kind of discuss a little bit specifically on the liquid BBLs and boob jobs. So, Professor Lees, if I can come to you first. As we know, liquid BBLs and liquid boob jobs have gained popularity in recent years. What specific risks are associated with these procedures?
I perhaps better explain that there's two versions of enhancement of large volume areas like the buttocks, and it is typically the buttocks because implants are used for the breast area, but it can be both. So surgically, we tend to use fat graft, which is from that person's own body taken from one place and then re-injected into the target area. And then what's called liquid BBL is an off-the-shelf filler. For example, Restylane, but it can include silicone, free silicone. And from what you've just heard, you'll understand the implications of that. So a number of filler materials typically being injected under a local anaesthetic rather than under a general anaesthetic in a hospital. So one of the big issues is the environment that this is being done in, which may not be a sterile environment, may not be clinical, may just be on the high street. And that's very concerning. And the other clearly is informed consent about the risks that somebody's running. And if you do inject any of these materials, be it fat or filler injection, and you hit one of the large veins in the gluteal muscle, that can result in the material travelling around into the lung and causing a pulmonary embolus. That can be fatal.
And thank you. And just so I'm clear, so that the non-sterile environments that could lead to infections, and is that correct?
Yes, it's a very serious matter for any of these procedures or indeed other surgical procedures to be performed in a non-clinical environment. So the confusion of the term beauty clinic makes it sound like a clinic, but it's not. What we're talking about is a medical clinic which comes under the regulation of the CQC and the medical practitioner under the GMC, versus the high street clinic, which is under the Environmental Health Authority, and they're not clinical specialists.
Thank you. And then, Ashna, and I know you just discussed this, but were you aware of specific risks associated with these kind of procedures?
Me?
No, Ashton, sorry.
Ashton.
Oh, but and you, Sasha, I'd like to hear if...
So from us as an organisation, we became aware really of how severe the risks with these liquid BBLs were in 2023, and we launched a campaign at the end of 2023 calling for the government to restrict the administration to plastic surgeons only in CQC regulated settings. We've helped over 700 women who have fallen foul to these types of practices and ended up in hospital with sepsis and needed corrective surgery, and I cannot stress strongly enough the impact that these procedures have on both their physical and their emotional well-being.
Yeah, and Sasha, you were not informed of any of the risks before you went for...
No, none whatsoever.
Yeah. And if I can just come back to you, Professor Lee, so can liquid breast augmentations make it more difficult to accurately screen for breast cancer?
It's not commonly done. Generally, our surgical community would offer breast implants, but we do also use autologous fat, maybe a combination of the two techniques together. And when that was first described, there were concerns that the fat graft might cause some confusion because it got a little bit lumpy and might be mistaken for a breast cancer lump. But those concerns, if you will, haven't perhaps borne out in practice. So people are more comfortable with doing that surgically now. But if we're talking about filler materials, then that could certainly confuse diagnosis.
Yeah.
And that is a safety issue, clearly.
And how do those risks compare with a surgical BBL or versus or a breast augmentation?
So the comparison of surgical versus a liquid butt lift, there's not really good data on this, and it's one of the problems we have in the whole area, that we don't have really good data because practitioners, non-surgical practitioners are not recording outcomes. We are calling really for government to make an amendment to the Health and Social Care Act of 22 to restrict the practice of cosmetic surgery to surgeons who are board certified in cosmetic surgery. The board certification is something that's been supported by the 4 royal colleges, including that of Ireland and of the relevant surgical specialty associations. So a lot of time and effort has gone into building this programme, which demonstrates for those who hold the boards that they have a real commitment to safety. They've reached the training requirements. They've got experience in dealing with this. They've undertaken professional masterclass in communication skills with patients. They reflect on their activity. They audit their activity. They do an annual appraisal, including a whole practice element. So if they practice cosmetics, that's included and is part of revalidation. And that's really to say there are people there that the public could access and hopefully have a good experience.
Thank you, Chair.
Thank you, Shivani. Sasha, thank you so much again for being here. Could you tell us a bit about your experience of getting a liquid Brazilian butt lift, please?
Yeah, my journey started many years ago with an asymmetry on my body. It was never to do with, wanting a big Kim Kardashian bum or anything. I had a very, very flat glute muscle on one side compared to the other side. So I started off on my exercise journey, didn't work. I then did look into the cosmetic journey, to the surgery journey, but that didn't work for me. I had to gain some weight. I went to have some the fat taken out of my body, and then when it was went to be transferred into me, I wasn't well. So the surgeon said it's not safe to continue on. So had the fat taken out, but I couldn't have it transferred. So went back to my exercise journey to try and correct this asymmetry, and it was a big deal for me. So I'm tall. I find it hard to get clothes after I'd had my children. I kind of gained a bit more weight around the middle, and so I was very narrow on my hips and very flat on one side, and it became even more challenging to get clothes for me. So when the gym wasn't working and then this liquid BBL was coming through, the clinic that I was going to for my anti-aging bits and bobs, they said there's this new filler coming out, it's really safe, it's hyaluronic, it's what you have in your lips, and you've had your lips done before, so you're going to have no reaction. And I was like, wow, this is fantastic. So I entered on my journey with them. They asked me if I could be their model, which I did, and I had it done, and it was actually okay the first time. Excruciating pain, but I was okay. I was just pleased that there was something that could. And they said you'd probably only need a couple of 100 mil. You need to do the other side as well as that side to get it looking the same. So, a couple of 100 mil, you'll be good. No, it was very apparent that it was then going to have to be an ongoing situation because you could see where the filler was sitting. So I had it done a second time, and we thought that was going to be good. Again, the pain was excruciating. I didn't actually know if I could then embark on it a third time. I did, and the third time there was problems. I don't know whether it was just the volume of filler that was, there was a sort of 200 mil in that side now. I started to get an infection. I ran the clinic. They said, just take some antibiotics. As blasé as that, just take some antibiotics. I did actually have some antibiotics at home, but by this time I was oozing all down the leg, and I thought, this isn't good. Anyway, the antibiotics cleared it all up, and it was okay. A few months on, it started going a bit of a weird shape. And so I actually spoke to the senior, but she was their nurse, effectively. It transpired she wasn't a nurse at all. She was just anybody that can carry this out. She said to me, look, I reckon we just need to do another couple of 100 mils. You're going to be done. You're going to be fine. And I said, I can't afford this anymore. It's so expensive. And I'd been their model and stuff before, so I didn't have to pay the... So she said, come to my house. I have a clinic at my house, and we'll do it there. which I did. In itself, it, you know, first glance, it looked okay. It was sterile enough until I was laying down, and I'd halfway through, and my partner, who was in the room, noticed the state of my feet, and he said, "Oh, I used to really like your feet until I saw the state of them." And I kind of looked back at my feet, and they were black. To which she turned round. Her mum had come in and was sitting in the end of the room as well, and had to go at her mum for not sweeping the floor when she'd done her client's hair.
Oh my God.
So that was that.
Okay.
So I remember thinking, okay, this isn't good, but it's too late now, let's finish. I'd say immediately we finished that, we're just getting out of there. It was cold anyway, it was like the 30th of December. My temperature just dropped out. I remember getting home and it was 35 something. I could not warm myself up, couldn't have a bath because you can't get it wet. And I said to my partner, I'm going to go to bed. Unbeknown to me, the sepsis was creeping in. So I kind of lost all sense of reality for the next couple of days until, yeah, the ambulance was called on the 2nd and I was in full-blown septic shock. And yeah, that's where my kind of journey began.
My goodness. Thank you for sharing that, Sasha, and I'm sorry you've had that ordeal. Obviously there was the immediate sepsis. Was there any long-term health complications following this?
Yeah, so obviously I was admitted into hospital. I was transferred immediately into ITU. My family were told there's no chance of 5%. I was then, in ITU. A few days later, it was apparent I was struggling to breathe. So I was put into a coma for 5 days. They just, whatever they were doing, it wasn't working. I had a heart attack. My kidneys failed. My lungs collapsed. It was pretty much just hopeless. I don't actually remember anything pre-coma, from being in A&E to ITU to the coma, but I remember being in the coma. I remember my partner trying to do a rose in my what was long hair then. My daughter obviously telling me to fight, my dad telling me to fight, and I remember trying to signal to say, "I'm fighting, I can hear you." And I did, obviously, I made it. So 5 days later they woke me up out of the coma, and it was the most traumatic time. That the terrors I had, Ian Huntley standing in my wardrobe trying to get me to go in there, and just all these nightmare things happening to me. But I was in hospital for the next 5 weeks, just getting better. They couldn't really get the infection under control. They were trying everything, but eventually after about 4 weeks they said, "You can go home." I went home with my lines in and went home to recover, where I had to learn to walk again, because obviously laying flat for 5 weeks. And so I'm left with, I've had an MRI of my brain, because walking and talking at the same time is challenging. I've got weakness on my right hand side. I drop things with my right hand, and whilst I've got no brain damage, they felt that I've got small vessel damage, which will just be enough to keep me, displaying sort of weird symptoms. I've got ongoing kidney issues, which I've got to have checked out. My lungs keep having to be checked. My heart, I've left with a leaking heart valve. I struggled with my business and me and my partner's business, so all last year I couldn't really work, so the business was in real jeopardy. It was only because partner and family stepped up to try and help to, I have a mortgage, I had my children, I had to look after, and I've completely, the last year, have been unable really to do anything. Then I lost all my hair. It's profound, the impact. And what's made it even worse is there's a grey area with all of my issues. So whilst had a heart attack, because they treated me so quickly, I thankfully don't have any muscle damage. So my critical illness will not pay out for my leaking heart valve because they don't cover it. So there is no recourse for everything that I've been through, and not being able to pay my mortgage and stuff, they won't pay out. And because the clinic, there's nowhere to go with them, you can't sue them, because even though my solicitor, he got a court order sorted that was handed to the clinic and to the girl that did me, they won't pass their insurance to it. Even though there's a court order, they're just saying no. And they don't have to provide that. So there's absolutely nowhere for me to go with this. There's no recompense. That's just it.
Is this clinic still up and functioning?
Yeah.
You know, it is.
Clinic are saying that it's not their fault because I chose to leave that setting and go to the girl's house. But we know, Ashton knows, that yes, whilst my setting was not sterile and not ideal, there are many clinics that are sterile and are ideal. I saw on that Olivia Atwood case with the gentleman that was going on about how sterile it was, and he was using the top of the art laces, and the girls still get sepsis. And what concerns me is poor Alice that died last year. I mean, I don't know the circumstances around her, whether she had a blockage or, you know, whether the other girls, they had blockages. Or I didn't have a blockage, I just got sepsis. Some girls got blockages, some girls got sepsis, is it the filler? Is it the area? Is it the lidocaine? We don't know what's causing all of these issues. And
I mean,
it's crazy.
You said just sepsis kills.
Yeah.
So
yeah,
I think what you've described is horrific. But clearly you're not the only person that has experienced this. Sasha, what would you say to somebody that was considering cosmetic surgery now, of any kind?
It's hard for me because I understand why women do it. I understand, not even the peer pressure, I worry about the young girls. I was saying to Ashton just before, I'm so thankful now. Obviously, I never wanted my daughter to witness what she witnessed. But I am so thankful that she is not going to go on that journey. And so I understand why women do. I can't sit here and say, don't do it, because, so many women are doing it. But at least do your research. And with this BBL, these are being carried out by anybody. They don't need any qualifications. And the irony is, my daughter, the day that I was taken into hospital, went to the very clinic whose girl did this to me and was training to be an aesthetic, carry out Botox and lips. And obviously she paid a lot of money for that course, and she won't touch it, she won't go near it. And so
there is a real imbalance here, that if somebody had beaten you up and caused the amount of damage that this woman had done to you, in any other setting, they would be behind bars. Ashton, what measures are in place to track and report adverse events related to non-surgical cosmetic procedures? None.
No. So the MHRA operate a yellow card reporting system for dermal fillers, but again, it's at the discretion of the practitioners, and many of the people that are carrying out these liquid BBLs are unscrupulous. They're advertising them as being risk-free, pain-free, no downtime. All of that is complete lies. And Sasha's story isn't isolated. We have dealt with over 700 women, many of whom have been in very similar situations to Sasha, nearly lost their lives. Their loved ones have been called in to say goodbye. They might not make it through the night. Some of them have been told they might wake up without their legs because the abscesses and the sepsis has gotten so severe. We've had one death related to these procedures, and these are surgical procedures that should not be being carried out on the high street. They are being carried out in people's living rooms, in Airbnbs, in hotel rooms, by people who are using products that they're buying unlicensed from places like China and Korea. They are decanting them from huge vats into individual syringes and injecting thousands of millilitres into people's breasts and buttocks. And then when things go wrong, they are misdiagnosing these problems and telling them there's nothing to worry about. And luckily, all of these women have taken themselves off to hospital, because if they hadn't, there would have been countless deaths in the UK because of this, and it shouldn't be allowed to happen.
Thank you, Ashton. One of the other inquiries that we have at the moment is female entrepreneurs. We know that the beauty industry is one where female entrepreneurs are growing, and it is fantastic to see. What is the sense amongst the kind of cosmetic industry about your campaigns to see the tighter regulations on this?
The vast majority of practitioners are 100% behind the fact that these procedures should be limited, because they are surgical. They should only be carried out by surgeons. And anybody that doesn't agree with that is not a scrupulous practitioner that has their patient's best interests at mind. You know, these treatments, even in the safer surgical hands, still pose significant risk. And so if you are a lay person with no medical background offering these incredibly dangerous procedures, you shouldn't be operating.
Thank you, Ashton. Rosie.
Thank you, Chair. Gosh, that was pretty shocking. Thanks so much for being so honest with us. I think people at home watching will be really moved by your story. Professor Lees, we're going back to just talking about education and informed consent, if that's okay. Are patients adequately informed about the risks of implants or wider cosmetic surgery, in your opinion? And are cases like Sasha's common enough for that to be factored in, do you think?
Well, Sasha was not treated by a surgeon, just to say that. So from the point of view of the surgical community, what we would recognise as best practice consent would be obviously a clinical assessment of the need for a procedure, be that physical or with psychological element, providing information both through stage discussions, through written generic information, and then personalised letter to the patient as to the facts, the pros and cons, and trying to work with the patient as a partner to reach the right decision for them. We recommend 2 consultations with a cooling off period, 2 weeks apart minimum, so people don't consult with a non-doctor, meet the doctor 5 minutes before the operation and then go straight into surgery and then regret it, because we want people to be suitably supported and happy with the procedure and have successful outcomes. That's what we want. So clearly informed consent is key. Is it what always takes place? We have no idea. But we obviously, as responsible end of the practice, will be auditing our results. We can look at outcomes, satisfaction surveys, and these things are all doable, of course.
Thank you. So is there a problem with regulation? Because obviously you're one end of the scale, and then we've got these people doing it in their houses. That it seems like anyone can do anything, and, you know, in a way your reputation might be damaged by this, and the other way around, people are going to assume the same standards are going to be carried out at that end of the market.
Yes, I think that's absolutely right. And one of the problems is because we have such a degree of regulation in this society around all sorts of things, the public thinks that all of this is regulated when it isn't actually. So we really are asking, if we may, Chair, through yourself, for the consultation which took place in 2023 around the regulation of non-surgical procedures, just to ask the question of the Secretary of State when that might be published and we get to learn of his determinations around that. I think that would be really helpful, because clearly there's no regulation around who can do what, and we have non-doctors doing operations, as you've just attested to, and misrepresenting themselves to the public, which is a really difficult dynamic and something that we'd like to see ended.
Thank you. And do you think there's adequate informed consent given before procedures like Botox and what we sort of everyday kind of procedures?
No, and just drawing back on the data that we've gathered over the last 10 years, over 90% of the people that we engage with that have had procedures gone wrong or unwanted outcomes haven't been appropriately consented or consulted before having the treatment. They're not explained what the risks are, how that practitioner would mitigate those risks should they occur. And what we do see is that when these unexpected things do happen, the lines of communication are closed down completely. They're often blocked and ignored and left to fend for themselves. So the consultation and consent process is something that is incredibly important but is incredibly lacking, and especially amongst the younger age group, like I mentioned before. They are, these procedures are incredibly trivialized amongst that age group. They see them as an extension of their beauty regime, like getting your hair done or your nails done. They don't have any medical association at all, and so they are so vulnerable to be exploited into thinking that this is a transactional type treatment. So we see scenarios where they're just sat in a waiting room with numbing cream on, they're brought in one by one, they have the treatment, they pay their money and off they go. And so it is a very real problem, and even more so when you consider higher risk treatments that are really surgical, like the liquid BBLs and the breast augmentations, because they are being missold on an enormous scale.
Thank you. How else can we better educate people? Obviously you're doing your bit and people who've survived are doing their bit, but what role might Parliament play?
I think education would be key, even where legislation exists. So, for example, Botox is a prescription-only product, but in 96% of the Botox complaints that we deal with, people don't realise it's a prescription-only product and therefore have no expectation that they ought to be seen by a medical prescriber before having the treatment. And so I think even where rules and regulations do exist, without that public education to empower them to make safer choices, no rules are going to be, robustly enforced, because the public need to be aware that they exist in the first place.
Wow, so when people go and get a bit of Botox, let's say a dental practitioner or something, that's not actually supposed to happen because it's supposed to be prescribed.
So
I know people here that have that done.
Yeah, so exactly that. So anybody can inject Botox, so your beauty therapist, any sort of layperson. There are no rules around who can and can't inject it. But because it's a prescription-only product, every patient should be seen in person by either a doctor, a dentist, a nurse prescriber, or a prescribing pharmacist. And that is something that is grossly under-enforced at the minute and under-policed. And what we're seeing a huge increase in as well is that people are now circumventing that prescription element altogether and are buying unlicensed products and illegally importing them from places like China and Korea, with devastating consequences as well. So I think if the government were to tighten up on those two pieces of legislation, both of which are in place at the minute, and they were properly policed and properly enforced, it is estimated based on our data that around 80% of the complaints that we've dealt with, it wouldn't have happened in the first place. And they would have been appropriately dealt with and managed if that system was more robust.
Wow, thank you. Finally, Sasha, thank you for being so brave again. Do you feel that you had enough informed consent from the beginning of your, 2 or 3 procedures? Or would it have changed your mind if you'd had more information, do you think?
Absolutely would have changed my mind if I had more information. But like as Ashton was saying, it's so played down. It is literally like, oh, well, you've had it in your lips. It's like no different. It's not painful. Yeah. And you're literally sitting in the same waiting room, just literally just, with the women in and out, even just going and having it done. You're in the same room, same environment, and you just think, but I think that's what lulled me into the sense of security. It wasn't going to hurt as well. I kind of just thought, oh, because it is just in that room where I've had my lips done, it's just going to be a little bit. But it really is a surgical procedure. So I was, misinformed to start with, and obviously I took the decision to do it again because I was on that journey. It was too late. I had to keep going. So, but interestingly, I signed a consent form that was the same you saying about the consent. The consent form was actually the same as having my lips done. And when I went to the other girl's house, she didn't get me to sign at all. There was no consent at all for it. So
Thank you very much. Thanks, Chair.
Okay, thank you. There's consent and then there's informed consent.
Yeah.
There are two different things.
Yeah.
Kirith, and then Catherine has a supplementary as well.
Thanks, Chair. Ashton, you and I met last year, I think, to hear about, or you told me about a constituent. For the purpose of the committee, I'll just tell the story a little bit. So Louise Muller experienced significant trauma following a botched liquid BBL procedure at a non-surgical clinic. She travelled from Bolton to Chelmsford in Essex for the procedure. She had been assured that the procedure would be carried out by a qualified professional with whom she had previously communicated. However, upon arrival, the treatment was instead administered by a man she had never met, later revealed to have not completed medical training. She'd already paid a non-refundable deposit of £435, so she felt pressured into proceeding. The procedure itself was rushed, deeply unprofessional. The practitioner walked in on her whilst she was undressing. He took photos of her buttocks without consent, acted aggressively during the treatment, and used the same needle on both sides, posing a serious infection risk. Within days, Louise developed sepsis and was rushed to hospital for emergency surgery to remove a life-threatening abscess. She sought this treatment in good faith, believing it to be safe and professionally conducted. Almost a year later, she's still not fully recovered, has lost her previous job, and is experiencing significant mental health challenges. Ashton, do you think if Louise had been properly informed about the risks and how the procedure was going to be carried out, where it was going to be carried out, do you think she still would have gone ahead with the procedure?
Definitely not. None of the women that I've spoken to would have gone ahead if they'd known the risks. I mean, you know, it never occurred to me in my wildest dreams that when I started Safe Face 10 years ago that I would be one day sat in front of a family who's lost a loved one because of one of these procedures, and nobody, if they were told that you could potentially lose your life, you could end up in hospital with sepsis through one of these treatments, that you would go ahead. You absolutely wouldn't. These women have all been misled into thinking that these are risk-free beauty treatments when the exact opposite is true.
Thank you. Thank you very much. Thank you, Chair.
Thank you, Kirith. Catherine.
Yeah, my question is around public, kind of leading on with the public education side of things, and how, I mean, we're talking a lot about informed consent and how, if the government was to do a national kind of communications campaign saying to women, you know, these procedures aren't safe, don't have breast implants and don't have cosmetic and don't have liquid fillers, how might that impact though those people who've already had it done? What would, you know, I'm just thinking about the psychological impacts, or whether you think we should just really take the bull by the horns and do a big campaign so women do know the dangers.
Me? I think, you know, in terms of telling people they shouldn't have any sort of cosmetic procedure, I don't think is the right way to go. I think that might drive people underground into rogue practitioners. I think these, the vast majority of treatments, depending on patient selection, informed consent, can be safe in safe hands, where the benefits outweigh the risks. It's about educating people how to make informed decisions, how to avoid rogue practitioners, and really helping them to understand what their treatment options are and how to go about finding a safe practitioner.
Would either of the others like to comment on that? Oh, that's fine. Thank you, Chair.
Thank you. Catherine, we're moving on to section F, the regulation.
Oh, and it is me. So
apologies.
Here we go. So, are the current, this is for you, Vivian, please, are the current regulations regarding cosmetic surgery sufficient? And if not, what changes would you like to see?
We don't think that the current regulations are sufficient, in brief answer. Sir Bruce Keogh's review from 2012 was quite clear in seeking to address what regulation we needed, both in non-surgical and surgical interventions. And quite a part of that has not been enacted or finally adopted by government, and we would like to see it. There is value in thinking of it as both happening together. We think it'd be really helpful if the surgical side could be regulated along with non-surgical, because out there we've got practitioners who think they are surgeons, who are doing procedures. So perhaps the very high-risk interventions are kind of falling in the middle. So it would be helpful to regulate all at once. From the surgery side, we've got the board's certification ready to go, and we have a lot of people signed up to that. A lot of people are busy getting signed up to it, so it is a solution if it's wanted. So the KEO review wanted the right practitioner and proper providers, by which I mean the hospitals and the actual clinics working together. He asked for high quality care with prostheses and other injectables. Injectables are classified as devices to make sure that they're properly sourced and safe to use. So that was partly addressed through the National Breast Implant Registry database, but clearly from what you've heard earlier, some issues outstanding there. An informed and empowered public. One of the difficulties we have is that however many communications we put out from a place like the college is not necessarily what people are listening to. And we tend all to be in our own echo chambers on social media. Quite difficult to get past that. But we need accessible redress and resolution when things go wrong. And at the English College, we're supporting the Daily Mirror campaign, which wants cosmetic operations to be done by trained surgeons who are on the relevant specialist register. Currently in law, there's nothing to stop a GP undertaking procedures if the patient consents to it. That's a gap. All operations and high-risk procedures must be in safe environments inspected by the CQC. That's the Daily Mirror's other ask, and for it to be a legal requirement for beauty clinics to have some malpractice insurance for the non-surgical interventions to help support patients if things do go wrong.
Thank you. And why do you think regulations regarding who can perform cosmetic surgery are not as stringent as other types of medical intervention? Why is that?
Well, largely because it's practiced in the private sector. So there's a lot of guardrails within the NHS to make sure that high quality standards are applied and maintained, but that's never happened within the private sector. So it's clearly one area which is desperately needing some regulation.
Thank you, Catherine. Natalie.
Thank you. Thank you for everything that you've told us today and all the things that we've learned. Really harrowing, and thank you for the work you're doing around raising awareness. So to Ashton, what steps are being taken to ensure that cosmetic treatments like Botox and dermal fillers are administered by adequately trained and qualified professionals?
From our perspective, we run a PSA accredited register which only permits registered healthcare professionals onto it who are competent to prescribe within aesthetic medicine, and we take all of those individuals through a robust 116-point check. We inspect every clinic listed on our register to make sure that not only the person holding the needle is trained, qualified and insured, but the environments in which they work from are safe and hygienic, and the products that they use are licensed and fit for purpose. And we also, picking up on the informed consent angle, we also take them through a role play scenario where they have to take our assessor through a informed consent, either for dermal fillers or for Botox treatments, so that we can be assured that whenever a patient visits that clinic, that they fully understand exactly what they're embarking upon, so that they can make an informed decision as to whether or not to go ahead.
Yeah, thank you. I've been having a look at your, you've got some clinics near me that I'll absolutely take a look at. What qualifications should practitioners possess to perform non-surgical procedures, and how can we ensure that these qualifications are consistently adhered to across the industry?
It's a very difficult question because the level of training varies greatly because of the lack of regulation. There are recognised qualifications that are available through Ofqual and university outlets. But from our perspective, because we only register healthcare professionals who, by virtue of their initial backgrounds, have an understanding of anatomy, physiology and pharmacology, they can, select appropriate training courses based on how they feel those things meet their competencies in these areas. But I do think for the general other spectrum of practitioners that offer these treatments, i.e. the non-regulated healthcare professionals, more needs to be done to ensure a standardised approach in terms of qualifications, because at the moment it varies so significantly.
And I think you've already covered this, but it's definitely worth asking because it's so important. Is there adequate oversight and enforcement of regulations for those administering cosmetic treatments?
No, in short, and I think the thing that we've observed over the last 10 years is that, people complain that this sector is unregulated, which in terms of who can and can't do these procedures, that is true today. But there are pieces of legislation and regulation that do exist that should be safeguarding patients having these treatments today that are being grossly under-policed and under-enforced, like, for example, advertising rules, remote prescribing, illegal imports of unlicensed medicines. And like I said, if those things were adequately policed, then we would see a huge transformation of the safety in people having these types of treatments.
And brings me on perfectly to the next question. What are the consequences for practitioners who operate outside of the regulatory framework and administer these unsafe procedures?
At the moment, very little. Like Sarah mentioned earlier, if what happened to Sasha and all these other women happened in any other context, these perpetrators would be behind bars, they would be charged with assault and GBH, and actually what these women have been through is technically assault. But out of all of the women that we're supporting, we urge all of them to go to the police and make formal reports. And not one of these cases, outside of Alice Webb, who lost her life, has been taken seriously by police departments. And women are constantly being perceived as silly individuals that are making decisions through vanity, and therefore their complaints are not being taken seriously enough by regulators, and they're being failed.
Wow, thank you. So what changes would you like to see to current regulations and practices in the UK?
I've long called for a task force which would span all of the regulators that currently have a responsibility within this sector, the MHRA, trading standards, the statutory bodies, to meet regularly to make sure that there is accountability within those departments, that complaints are being investigated and followed up and action is being taken, and to preempt emerging trends. Like Vivian mentioned, we would like to see mandatory insurance for all practitioners, because around 80% of the people that we help can't seek any financial compensation because the practitioners are not insured. And we'd also like to see, which is something that we are hugely concerned about at the minute, is the reclassification of certain fat dissolving injections that are being used for cosmetic indications, which are currently only regulated through the general product safety regulations, which means that the manufacturers are not duty bound to prove that their products are effective. They don't have to go through any safety or efficacy trials. And I think it is a crisis waiting to happen, that we'll have an untold number of people coming through with various health issues that are not being captured because of the grey area in these regulations. But I think for us, the most important thing is for Alice's Law to be enacted to make BBLs illegal for anybody to do them other than surgeons in CQC regulated hospitals, because we cannot be in a situation where somebody else loses their life because of one of these procedures.
Thank you.
Thank you, Natalie. On this, is there a risk that we are going to have to constantly keep ahead with the law? Law is slow to change. We've seen that. How do we keep current, and how do we ensure that we are one step ahead of bogus practitioners that will use emerging technologies and tools as part of their arsenal to, say, trick people like Sasha, for example, or anybody into having a procedure that isn't safe?
Yeah, and I think that's a very, very difficult issue that, you know, needs to be addressed, because if you look at the most dangerous of practitioners, they operate like ghosts. And so what tends to happen is they entice people through social media. They have spurious names like Amy's Aesthetics, for example. Amy comes to your house, or you go to a pop-up location. She does the treatment. You may have a mobile phone number if you're lucky. If not, you've just got his social media contact details. And when things go wrong, Amy blocks you. And you've got no fixed address. You don't know her full name, and then how do you go about contacting her? And then when the complaints mount up, she closes that page down and pops up somewhere else. And we've seen this time and time again with perpetrators of these liquid BBLs. You know, we've had individuals where they've caused over 39 people to end up in hospital, yet they're free to carry on with impunity.
Thank you. Professor Lees, what are the primary risks associated with travelling abroad for cosmetic procedures, and is cosmetic tourism having an impact on the NHS, do you think?
Yes, I was going to say that we regularly, on the emergency take, on call, have people in, both from this country and from overseas, who've got acute problems that cannot be sorted out by the people who originally did the treatments. In the case of practitioners here, because they don't have the skill set to sort them, and in the case of overseas tourism, because the patient's too poorly or has otherwise lost confidence in the facility that treated them, so aren't going to go back again, and it will probably be unsafe for them to travel in any case. So I've seen things like a young woman with infected filler injections in the lips, having to have chunks of her lip cut out. You can imagine what that will be like for her over a lifetime. I've seen infected buttock implants coming out, abscesses, collections, bleeding problems in the middle of the night from clinics, actually medical clinics here that don't have the ability to treat their own complications, so that lands up with the NHS, and it's turning into a significant burden of work, particularly for the plastic surgeons, also for the breast surgeons on their service, and clearly that's something that needs to be thought about.
Thank you. Catherine?
Yeah, just a question, I think, for Professor Lees around, we talked earlier about the NHS list. I can't remember exactly what it's called, the kind of register.
Yes.
And you said some improvements are needed on that. And I wondered if you could outline what those are. And then the wider question, if we have time, is just around, do we have enough data on this problem across the whole of the UK, all the different procedures? Are we gathering the data around Sasha's procedure and around other procedures as well? Is there a kind of central register so we can keep an eye on these things?
There's no register for non-surgical procedures. We have FIN data and on the NHS HES data, which captures the private hospital and NHS work. So we are looking at coding for work that's been done overseas that has generated a complication. This will take some time to come in. In terms of the implant registry database, I thought the suggestions made earlier were actually helpful in terms of using that database to perhaps gather more information and to provide practitioners with an annual summary of emerging trends so that they can better counsel and inform the next set of patients that are presenting. That seems sensible.
Sorry, before Catherine comes back, can I just ask, you said it will take some time for this coding to include overseas cosmetic procedures. What's the time frame for some time? Because my definition is very different to, say, my little girl's.
I'd like it done immediately, of course, but my understanding is that the HRG codes are only varied twice a year. So we'd hope to come into the next batch.
Thank you.
That was it, really. Thank you. That was it.
Thank you, everyone. Has anybody... Kirith has got a question.
Final question. So, Ashton, you used the word perpetrators earlier. I wanted to ask you all, do you see this as another form of exploitation of women?
Absolutely, and you know, not only are they being exploited and let down by the people that are doing these procedures, actually they're being let down by the system that is designed to protect them at the minute. Like I said, you know, the police aren't taking this seriously. Very few regulators currently take these issues seriously, and I do believe that that is because of the perception that they are related to cosmetic treatments, and therefore it's kind of the women's own fault, which is, you know, it needs to change from the top down.
Yeah.
Absolutely.
I think as well, when something's gone wrong for you and you've approached a practitioner to have something done in good faith, you feel really shy about coming forward. It's not easy to do that.
Yeah, of course it's not.
You know, your account has been very, very moving. It's not easy to complain about some of these things.
No.
And we need to understand that as well. 94% of cosmetic operations are received by women, only 6% by men. The global market for cosmetic surgery is going to grow threefold, it's estimated, within the decade. So we're going to see a lot more problems in terms of absolute numbers, and we need to set up a structure that will adequately support legitimate work.
Do you want to... Thank you so much for sharing your story earlier.
Thank you.
I'd like to see it just banned, basically.
Yeah.
Really, really would.
Yeah.
So,
thank you.
Yeah.
Thank you very much. I think we have had an incredibly powerful and informative session. I am so grateful to all of our panellists and you three as well for how fantastic you have been able to articulate the issues, the problems, the solutions. Quite often sometimes we get panels and witnesses and experts that might give us different ambiguous answers.
Yeah.
You have been clear at what needs to change, and I am so grateful for that, and I know the rest of the committee is as well. Thank you very much. That brings this session to a close. Order.